Good afternoon, everyone, and good morning to those of you that are joining us from the West Coast. My name is Alexa Eggleston, and I am the Substance Abuse and Addiction Project Director for the Council of State Governments Justice Center. I want to thank everyone for joining the National Reentry Resource Center's webinar on recidivism reduction, substance use, and co-occurring disorders. What does evidence and practice tell us? This is part of a webinar series that the Reentry Resource Center is sponsoring that focuses specifically on best practices for working with individuals with substance use and mental health disorders who are justice involved. Please be on the lookout for future webinar announcements over the next few months. Today we are joined by Dr. Roger Peters, professor at the Department of Mental Health Law and Policy at Louise de la Parte Florida Mental Health Institute, University of South Florida, and Dr. Fred Osher, the Director of Health Systems and Services Policy at the Council of State Governments Justice Center. Dr. Peters has been a faculty member at the University of South Florida since 1986. Dr. Peters has served as principal investigator and director for several grant projects, including USF's Center on Co-occurring Disorders, Justice, and Multidisciplinary Research. Dr. Peters has served as the lead consultant to the National Gain Center for People with Co-occurring Disorders in the Justice System. He has published frequently in major journals, served on federal expert panels, national advisory boards and committees, and has served as a consultant to federal and state agencies. He served as chair and co-editor of the SAMHSA CSAT Treatment Improvement Protocol on Substance Abuse Treatment for Adults in the Criminal Justice System, published in 2005. Dr. Peters received his PhD in clinical psychology from the Florida State University following completion of a predoctoral internship at the University of North Carolina School of Medicine. Dr. Osher oversees the health components of the CSG Justice Center's initiatives. He also provides technical assistance to state and local governments across the country seeking to improve their response to have people who have mental health and or substance use disorders and are involved in the criminal justice system. Before joining the Council of State Governments Justice Center, Dr. Osher served as the director of the Center for Behavioral Health, Justice, and Public Policy and as an associate professor of psychiatry at the University of Maryland School of Medicine. He has published extensively in the areas of homelessness, community psychiatry, co-occurring mental and addictive disorders, and effective approaches to persons with behavioral disorders within criminal justice settings. He received his BA from Harvard University and his MD from Wayne State University. Today's webinar is focused on treating substance use and co-occurring mental health disorders and matching treatment to the target population, both of which are essential for improving individual outcomes and public safety. The presenters will discuss the importance of screening and assessment, the evidence-based treatment practices that help to reduce recidivism for people with co-occurring disorders, including how to incorporate criminogenic risk assessments into treatment decisions, and the importance of collaboration and coordination between system providers to ensure the most effective co-occurring treatment. There will be a question and answer session at the end of the presentations. To ask a question, please type the question into the Q&A panel on the bottom right-hand corner of your screen. Please feel free to ask questions throughout the webinar, and we will answer them at the end. We will do our very best to answer your questions, but please understand that this is a very large webinar, so your question may not get answered. In that event, please follow up with the Reentry Resource Center directly. If you do encounter technical or audio problems during the webinar, please call WebEx technical support at 1-866-229-3239. We understand that there are some technical issues you may not be able to resolve in time to participate in this webinar. For this reason, we are recording the event and will be posting the recording on our website within a few days. The URL for our website is www.nationalreentryresourcecenter.org, and we will also be circulating that information through the chat box throughout the presentation today. We really appreciate Dr. Peters and Dr. Osher taking time out of their busy schedules to be with us today, and now I would like to turn it over to Dr. Osher to begin the presentation.
Well, thank you, Alexa, and thank you, all of you, for taking time out of your busy schedules to join us. We hope to talk to you for a little over half an hour, but then respond to questions as they come up, as Alexa had outlined. What we will do in our discussion with you today is provide an overview of the concept of evidence-based practices, a term that's widely used at this point in time, but not always accurately so. and try to then discuss the application of EDTs to individuals with co-occurring substance use disorders and non-addicting mental illnesses. We will focus on those individuals that are justice involved, given the nature of your work and the National Reentry Resource Center. Dr. Peters will then talk about what works for individuals that have high substance abuse needs but don't meet criteria for serious mental illness. And I'll be discussing in a moment a quadrant typology that we use to explain the heterogeneity of the population with co-occurring disorders. Following Dr. Peters' discussion, I will talk specifically about those individuals that have more severe and serious mental illnesses with co-occurring substance use disorders, and that will be followed by our discussion. We'll start with the definition of evidence-based practice, and this is from the Institute of Medicine, the integration of best research evidence with clinical expertise and patient values. Original and earlier definitions did not include patient and client values, and the current definition represents the centrality of our consumers and clients in working towards recovery goals and staying out of justice settings. There is a science behind evidence-based practices, and that it really is important for us to remember that it is an iterative process, and that this pyramid is used to represent the process at which practice moves into consideration for evidence-based practice. And we start with all of our work in the field, pilot studies, case studies that we do in which we think we have a strategy or an intervention that makes a difference. That then gets tested in a group of individuals, sometimes using a simple design. They experienced certain outcomes, got an intervention, and afterwards had differences in those outcomes. That's a pre-post design. That isn't quite as good methodologically as randomly assigning individuals to interventions, which controls for some of the biases that might come with group cohorts. And in these quasi-experimental designs that show positive outcomes, we get increasing confidence that if replicated, those outcomes will be achieved. And moving up the pyramid, there's a level of rigor as we try to move from single populations to multiple populations, single studies to multiple studies, and we can aggregate studies on particular practices, do a review, a meta-analysis, and if it continues to show consistent and positive outcomes, it is typically addressed through either a Cochrane review or a submission to SAMHSA's NREP, but a review of experts that then discusses the merits of the particular practice and will include it in lists of evidence-based practices. So the pyramid here is just to remind us that there are empirical data that we use to justify labeling a particular practice as evidence-based. Once one has a practice, it's important that one deliver it with fidelity, that is, true to the way in which it was designed. And fidelity represents the degree of implementation of an evidence-based practice. And if programs have high fidelity, they're expected to have greater effectiveness than those with lower fidelity. We have fidelity scales that we can apply to assess the clinical ingredients of an evidence-based practice. And as a practical example of why we might care about fidelity is this slide, in which it's a study that was done about 10 years ago, in which it was looking at individual participants that were on an assertive community treatment team. And the teams, and ACT is an evidence-based practice, the teams were evaluated for their fidelity to the model. And this is one particular outcome measure. That is the percent of individuals that had 6 months or longer of abstinence from their substances of abuse. And the bottom line in pink are those programs and those participants that had low fidelity. And the top line in blue are those programs with participants that had high fidelity. And what we see here are sort of the differences in outcomes related to fidelity. So the top line, about 15% per year, the participants are achieving the definition of remission that was a part of the study. And so just a reminder that knowing the evidence-based practice exists and putting it into practice requires attention to fidelity. I discussed with you at the outset the heterogeneity of co-occurring disorders, and that's the focus of our discussion. This typology here was developed by the National Association of State Mental Health Program Directors and National Association of State Alcohol and Drug Abuse Directors, in which there are two axes. On the x-axis is mental illness going from low to high severity, and on the y-axis are alcohol and other drug abuse going from low to high. And that, in effect, this then defines four quadrants. And we'll be talking more about this throughout the course of this webinar. But what's important to remember is that the needs of the high individuals, which are represented here in quadrant 4, are different than the needs and then the associated responses if their mental health or substance use needs are higher or lower. And so we want to start talking about the population of co-occurring disorders with some of the subtlety that's appropriate given the heterogeneity of the population. With that as introduction, I'd like to turn it over to Dr. Peters to discuss principally those evidence-based practices that are associated with the quadrant 3. I will come back in a moment and talk about the quadrant 4 EBPs. Dr. Peters?
Thanks, Fred. I'd like to start out with just a little bit of information about screening and assessment for co-occurring disorders as an evidence-based practice. And to start out with, let's look at the importance of good screening and assessment for co-occurring disorders. First off, we know that we need to screen for both disorders because of the high prevalence rates in criminal justice settings. We know that we have much higher rates in justice settings than the general population. If you have a mental disorder or a substance use disorder, you also have a much higher risk for having the other disorder. We also know that people that don't get detected with these disorders are likely to cycle back through the system, and this causes all kinds of problems. Very expensive, they take a toll on the system. And these individuals, as we know, are known to all different individuals in the justice system. So potentially, a good screening and assessment system for co-planning and linkage treatment matching to appropriate services. We can fast-track individuals into services, involve them in specialized co-occurring services as needed, and also prevent premature dropout and other treatment failure. And we know that effective treatment matching based on a good screening and assessment leads to better outcomes. So let's look at a few issues and actually providing screening and assessment for co-occurring disorders. I think first off, one of the challenges is there's a huge number of instruments out there, right? And we know that the number of instruments has really gotten much larger in the last few years. We see a lot of things out there we're not familiar with. So how to pick and choose from those instruments that are out there. One thing that we know about all of these instruments, they're not all created equal. In other words, they vary in their effectiveness. They vary in their psychometric properties of reliability and validity. So we have to be very careful about which ones to pick and choose it for our settings. There's also direct-to-consumer marketing of many of these instruments, some that have poor psychometric properties. So it's good to be a good consumer about the research out there in screening and assessment instruments. Which instruments have been validated in criminal justice settings, very important. Very important to use standardized screening and assessment instruments, and those that provide good coverage of both mental and substance use. So one thing that also is a challenge for us is we don't have good comparative data about the effectiveness of these instruments. There's a few studies out there, but one of the keys is to be able to contrast the effectiveness of these instruments. So we'll look at a couple that you might consider in the next minute or two. The goal, again, is to provide integrated screening and assessment that blends coverage of both mental health and substance abuse issues. Another key issue that we won't spend as much time today talking about, but that's very important, is trauma and PTSD, which is another key area due to the high rates among offender populations. So let's go on and look briefly at mental health screens that are out there, evidence-based screens. The good news, there's a variety of instruments available both for mental health and substance abuse issues. These are all public domain instruments. They're brief to administer, easy to score, no training required for the most part. And these instruments that we'll be presenting on both the mental health side and the substance abuse side all have thresholds and cutoff scores available indicating severity of either mental health or substance use problems. So on the mental health side, these would be some of the instruments that you might consider. All of them have very good psychometric properties, have been tested out for use with offenders. Again, they're very quick to administer, easy to store, and then can provide information about who might need additional assessment. On the substance abuse side, here's another 4 instruments that you might consider. Many of you are familiar with these. And these include the TCU drug screen 2, which is getting lots of traction lately in criminal justice settings based on DSM diagnostic formulations. But also the other instruments all have very good properties and have been used extensively with offenders and other clinical populations. Many of you are familiar with the GAIN instrument. We'll talk more about that later in just a minute. The ASI, of course, is the most widely used assessment instrument, but also has a very effective set of screens for alcohol and drug use within one of the sections of the ASI. So just moving on to assessment instruments, and again, just giving you a hint about some of the assessment instruments you might consider if you're looking for a good evidence-based approach. Again, here we're looking at more comprehensive picture of information about the co-occurring disorders. Again, the Addiction Severity Index, which is 45 to 90 minutes to administer in the public domain, which all of these instruments are, has 7 sections that cover a whole range of issues related to co-occurring disorders, also has severity ratings, which are very useful. Going on to the GAIN instrument, 2 versions that you might consider. The GAIN Quick is a brief assessment taking 20 to 30 minutes. That's about 10 seconds. It has 10 sections. The GAIN Initial is a little bit longer. It takes about 1.5 to 2 hours. Also very comprehensive in coverage. And then at the bottom, the Texas Christian University Institute for Behavioral Research has 2 separate assessment instruments that might be considered. One is 60 pages in 4 sections, which is a brief intake interview. The second is the comprehensive intake, which is 32 pages in about 9 sections. A little bit longer, has additional sets of sections on issues such as AIDS and HIV risk and so forth. So this, again, our assessment might be considered. We looked at some screen instruments as well. So now it's time to move and look at evidence-based practices and treatment of offenders in quadrant 3. As Dr. Osher mentioned, I'll be looking at offenders that have high needs in the substance abuse area and low to moderate needs in the mental health area. So if you will, here's just a conceptual model of treatment services for quadrant 3. Dr. Osher will be talking more about matching by risk level in a little bit. One of our goals is to use risk assessment instruments to identify offenders that are at higher risk, higher needs. And this allows us to triage to different levels of treatment, supervision, and so forth. We select the higher risk population after that assessment process has been conducted. And one of those populations, as you know, is co-occurring disordered offenders. Then if we look down at the lower right-hand side, I'll be talking about for the next few minutes about actual treatment strategies, evidence-based practices for quadrant 3. And I will mention several others than those that are listed here, but those are just some examples. And we want to intervene at quadrant 3 for that set of issues there. And then also important, as we know, is reentry services. We'll talk a little bit later. The outcomes for our populations are greatly magnified, improved outcomes when we have reentry services coupled with other core treatment services. And finally, we'll talk about specialized supervision approaches. And I think this is an evidence-based practice that gets overlooked. I know Dr. Osher will talk some about this as well, but I'll spend a few minutes in just a bit about talking about special supervision caseloads for those that have serious mental illness and co-occurring disorders. So just a model to think about in terms of quadrant 3 evidence-based practices. So I will be talking about the left-hand side of this gradient here. Dr. Osher will be talking about quadrant 4, the right-hand side. And we'll go through each of these in not a lot of detail. Lots of good information available at the SAMHSA websites, the NIDA websites, and so forth, and we'll be talking about some of those resources. Here's the set of evidence-based practices that I'll be focusing on for the next few minutes. We'll start with cognitive behavioral treatment. Again, these are all treatment practices for individuals with high substance abuse needs and low to moderate mental health needs. So first and foremost, cognitive behavioral treatment, we hear a lot about that. Many people profess to provide cognitive behavioral treatment. So I'd like to talk just a little bit about what it involves. When I think about cognitive behavioral treatment, primarily I'm thinking about skills-based interventions. And this includes a variety of different skills. Typically, the interventions are manualized, and we'll talk about that as well. There are manuals that focus on substance abuse. There are also manuals that focus on criminal thinking. We'll talk more about that, as well as coupling criminal thinking and substance abuse as well. I'd like to spend a little bit of time talking about what exactly cognitive behavioral treatment is, and here are the kind of features and highlights of the interventions, cognitive behavioral interventions. Again, I mentioned skill building is one of the keys, and that is a range of skills, including drug coping skills, stress management, communication, interpersonal skills. We also have self-control and self-management skills. We have anger management, dealing with urges and cravings related to alcohol and drug use. We have relapse prevention, which most of you are familiar with, which is a kind of a core cognitive behavioral intervention. A set of problem-solving approaches, identifying problems, brainstorming solutions, planning on how to implement solutions. And then some of the process elements of cognitive behavioral interventions are down below here. Do a lot of role play, modeling, and feedback, using a social learning model, trying to accelerate learning and skills retention through practice and immediate feedback provided in session. We also do a lot of repetition material. This is key for people with co-occurring disorders, of course. And skills rehearsal is very important to provide for different settings. For example, drug retrieval skills, a range of different settings that might be relevant for the offender population. Finally, we think of cognitive behavioral interventions as manualized. Again, just having a manual that you can implement increases fidelity, as Dr. Osher mentioned. Most of the cognitive behavioral interventions we'll be talking about do include a manualized approach. So I'd like to go back to the previous slide. And looking at the set of evidence-based practices in the 3, one thing I want to mention about the cognitive behavioral interventions is quite a big evidence base to support these. The Campbell collaboration meta-analysis that was conducted in 2007 found an average recidivism reduction of 25% over a 12-month follow-up period for cognitive behavioral programs involving offenders. Some very interesting findings. I'll just highlight these very quickly, but factors associated with the greatest reductions in recidivism, according to this meta-analysis, were high-risk status of participants. We mentioned that already. Higher quality of cognitive behavioral treatment implementation, as Dr. Osher mentioned, the fidelity and the ability to monitor fidelity of implementation. And then as far as the treatment elements were concerned, within cognitive behavioral treatment, what were found to be the most linked to reductions in recidivism were anger control, interpersonal problem solving, and cognitive restructuring, or recognizing and modifying distortions and errors related to criminal thinking. The meta-analysis found, interestingly, that there were no significant differences between specific types or brands of CBT, cognitive behavioral treatment. They were equally effective. There were also no major differences between custody-based programs and community-based programs. For example, for probationers and parolees. They were equally effective. So that's good news. These approaches, cognitive behavioral treatments, can be applied equally well in custody and non-custody settings. The study also found, finally, that CBT, cognitive behavioral treatment, is as effective for juveniles as adult offenders. So just a little bit of information about cognitive behavioral treatment. Moving on then fairly quickly to modified therapeutic communities. This is an area that we know a lot about. And there's a wealth of information, a wealth of studies about the effectiveness of therapeutic communities, or TCs, in reducing recidivism and substance abuse. The study found an average of 14% reduction in recidivism per year relative to no treatment comparison groups. And the findings are augmented greatly when you provide in-prison TCs followed by treatment in the community. These programs are very long-term. They're somewhat expensive if you think about it. For a small number of individuals over a long period of time, And because of that, we need some other options in addition to TCs to implement in prisons, jails, and other settings. We also want to point out that TCs have been modified successfully for co-occurring disorders, and we'll talk about some of the outcomes related to that in just a minute. Moving down to medication-assisted treatment, very briefly, many of you know methadone, naltrexone, buprenorphine all have strong track records of reducing substance abuse and crime. They're used to decrease cravings, reduce reinforcing effects of drugs, and also to assist in acute withdrawal. We know also that these medications are underused in probation parole settings and also in jails and prisons, particularly in custody settings. Very few of our jails and prisons take advantage of these medications. We know that, however, that offenders have similar positive outcomes to non-offenders in using medication-assisted treatment. Contingency management is another evidence-based practice you'll hear quite a bit about. And I won't spend a huge amount of time talking about this, but we're talking about an integrated system of incentives, rewards, and sanctions that target recovery behaviors such as clean urines. And essentially, these systems provide vouchers redeemable for goods and services, or using a fishbowl technique or other delivery mechanisms for the opportunity to draw prizes, for example, based on positive behaviors such as clean urinalysis. Contingency management programs have been shown to improve retention and treatment, increase abstinence, and also to improve medication compliance among persons with severe drug problems, including offenders. Very important technique. Motivational enhancement. Many of you are quite familiar with MET and motivational interviewing. Very important set of strategies for engaging offenders in treatment, strategies to rapidly promote internal motivation and address ambivalence to treatment and change. We know that we need to link here MET, motivational enhancement of the interventions, we're talking about controllers to impairment and self-regulation. We also know that from reviews of motivational enhancement approaches with offenders that the interventions are effective. With offenders, they improve retention and treatment, greater motivation to change, and reduced reoffending. One area that these techniques don't have much impact on is domestic violence perpetrators. Moving on then to relapse prevention. Very quickly, we talked about this already to the cognitive behavioral approaches, but numerous studies demonstrate the effectiveness of relapse prevention programs with substance abusers, including offenders, looking at high-risk situations, antecedents to relapse, and developing, again, management strategies to prevent relapse. Trauma-focused treatment, this is also an element of quadrant 4. There's several evidence-based treatment curricula available in this area. As we know, a large number of offenders have trauma and violence issues, a history of that. So there's a number of evidence-based treatment curricula out there that can be applied that are quite important to look at. And then finally, mutual self-help groups have been shown to enhance abstinence and retention treatment as well. So these are all the set of evidence-based practices that should be considered for quadrant 3. I want to talk a little bit about the importance of reentry planning for co-occurring disorders. I mentioned this before, that reentry treatment, particularly during reentry, can greatly enhance outcomes. The first 30 to 90 days following release from custody or residential treatment is absolutely critical. We know that this is when most people relapse and when they experience rearrest. We'll provide structured and supervised transition with rapid engagement and treatment during the reentry period. So these are some of the elements that I think are very important to consider. We want to have in-reach of community providers to help with assessment, to participate in the reentry plan, the relapse prevention plan, develop initial appointments, and so forth. Accessing restoring benefits is a huge issue, particularly for people with co-occurring disorders who frequently need to access benefits upon release. SSI, SSDI have oftentimes been suspended or discontinued due to incarceration, and there are processes to expedite the renewal of those benefits for offenders. Continuity of medications, oftentimes this is for people experienced great difficulties during reentry period. And the programs that have dealt with it successfully have made arrangements for supply of medication until the follow-up psychiatric consult is arranged in the community. Oftentimes a 30-day prescription is provided, and perhaps a 5 to 7 day supply of meds is provided to the individual at their point of release from custody or residential treatment. Down at the left-hand side, we want to have dedicated staff to coordinate this process, including case managers, other boundary spanners that are effective in planning for reentry. And finally, a systematic structured reentry plan is useful. One example is the APIC model that looks at assessment, planning, identification, and coordination of transition planning that it provides a practical framework for reentry planning from custody or residential treatment, identifies key service needs, and essentially a relapse prevention plan for offenders. Other issues, I won't spend much time on these issues as well, but these are very important in considering as part of the reentry and transition plan for offenders with co-occurring disorders. As people know, oftentimes these individuals have far fewer vocational skills, also need high intensity case management during this period. Outcomes, as I mentioned, for reentry are quite important and impressive. When you just take traditional substance abuse treatment, for example, in a prison TC, and add treatment in the community, studies show that 70% of individuals remain arrest-free after 3 years, in comparison to only 30% of offenders who don't receive this set of treatment services in custody and in the community. The graph that you see in front of you actually addresses the same set of issues with co-occurring disorders within a population received treatment in prison and then in a TC aftercare in community. And what you see is that for people who just received mental health treatment in prison on the left-hand side, you have 33% incarceration rate after 1 year. And for people who have the TC treatment in the prison that's for co-occurring disorders, you have reductions in recidivism in recommitment during that period of time. And then what you see on the far right-hand side is treatment in prison plus treatment in the community in a out-of-care TC. And there you see your rates of recidivism even further to flex out. So again, just an example of the magnification of results you get with reentry aftercare services. Finally, then, in closing, I want to talk a little bit about community supervision as an evidence-based practice. And here we found through Jennifer Skeem's work and others that specialized caseloads for those with serious mental illness and co-occurring disorders are more effective than traditional supervision. And what do we mean by that? Very quickly, smaller caseloads being less than 45 to allow more responsiveness to the co-occurring needs of the offenders and provide individualized approaches to treatment and supervision. More training, of course, 20 to 40 hours per year on average. Active engagement in treatment, both for substance abuse and mental health. We know that intensive supervision doesn't work very well without this involvement in treatment. And then finally, the dual focus on treatment and surveillance. It doesn't mean that we're giving up on surveillance. This approach is shown to be very, very powerful with special caseload for co-occurring disorders. And we find, as a result of that, that we're, number one, more effective in linking offenders with treatment services. But second, we have lower rates of revocation, arrest, and incarceration. And then finally, just in closing, these caseloads tend to use a problem-solving approach where we identify obstacles to compliance, generate solutions, and form a compliance plan. The probation officers tend to use a higher revocation threshold. For example, it takes more positive drug tests to have somebody revoked than it would ordinarily because they know that for people with co-occurring disorders that it takes longer to achieve abstinence. We have a wide range of incentives and sanctions available, and we flexibly apply the sanctions to consider life events and circumstances. For example, the types of medications that the individual might be on and how those medications might affect behaviors. And we accommodate relapses, as mentioned before, and also provide less punitive sanctions overall. Finally, we want to avoid sanctions with this caseload approach that removes participants from treatment. For example, extended jail terms often lead to mental health crises. So we try to use alternatives to jail like more frequent reporting, community service, extended curfews, and written assignments. And finally, the relationship quality of the officers is very important with the offender in these caseloads. There's a development of trust, caring, but also a sense of fairness, firm but fair, but avoiding the law enforcement or punitive stance that some caseloads typically have in probation and parole. So just an overview of EVPs with quadrant 3 offenders, co-occurring disorders. I want to turn this back over to Dr. Osher at this point.
Thank you, Roger. And we recognize that we're sort of giving a snapshot of these practices, and in the discussion period, we'll have opportunity to talk about how you might choose, apply, and in what circumstances these evidence-based practices can be considered. I want to focus on those practices that have been implemented with individuals with serious mental illnesses, those that have significant disability that are associated with diagnoses like schizophrenia and bipolar or major depressive disorders. And that I'll talk from this list on the right and then share with you some ideas about what you might do when what you need isn't on a list like this. I think that you'll see some parallel strategies between quadrant 3 and 4, and this is not meant to be exclusive to those individuals within those quadrants. Those quadrants serve as a planning tool, but at the level of the individual, it's that careful screening and assessment that Roger outlined at the beginning of his discussion that really will drive the case plan and then the selection of the appropriate evidence-based practices to address the needs that have been identified. Of course, in the co-occurring population, we want to emphasize the appropriateness and necessity, that is, of integrated dual disorder treatment. So we're talking about individuals that have both mental health and substance use disorders. They are frequently found in our justice population. They will probably be the modal people within your own program settings. We know that 3/4 of individuals with serious mental illness have a co-occurring substance use disorder if they're justice involved, and half of those individuals with substance use disorders will have a serious or another mental illness if they are justice involved. So it's critical that we think about ways in which those individuals can access integrated treatment both behind the fence and outside within communities. We know that without that integration, they're likely to end up with messages that are difficult to sort of put together on their own. We have a history of providing either no treatment or sequential treatment or parallel treatment, which hasn't delivered consistently good outcomes. And we do have a growing literature base to suggest that the provision of integrated individuals that have connections to the criminal justice setting is associated with reduction in recidivism for those individuals. The second practice, and it relates again to Roger's earlier point, that it is critical that there be adequate housing. We know a high number of individuals coming back into our communities had homeless histories prior to their incarceration, and that it is absolutely essential that one identifies a stable environment for them to live in. The concept of supported housing is that beyond just a home, it is important that the appropriate supports are delivered to those individuals to allow them to maintain their places of residence and also to move forward with their recovery goals. So supported housing is an evidence-based practice that's available, has been associated with reductions in shelter use and hospitalization, and also fewer days in jail and prison than those individuals that aren't in those settings. The third evidence-based practice is probably the most researched, a long-standing focus of the National Institute of Mental Health, and that is the psychopharmacologic interventions that are effective and associated with specific diagnostic conditions. So it is essential that individuals with co-occurring disorders, if they have schizophrenia, get access to some of the medications that can reduce the symptoms associated with that and provide some degree of organization to thinking. Bipolar disorders, mood stabilizers are required, depressive disorders, a range of antidepressants that are there. And as Roger had earlier said, the key is to figure out how to provide some continuity in the use of these medications, both inside and outside our custody settings, and also to figure out a strategy to promote adherence and then figure out how to finance them. Assertive community treatment, I had shown you a slide related to substance use outcomes as I was discussing fidelity earlier. We actually know that the literature on assertive community treatment as it applies to reducing recidivism is mixed, and that in part it relates to the fact that ACT team missions in and of themselves have not always focused on keeping people out of jail and prison. There have in recent years been modifications to the ACT teams to add forensic expertise with the direct involvement of staff joining the team and the staff on the team being experts in the issues that individuals within the criminal justice system deal with on a day-to-day basis. And the early literature on FACT teams are associated with reductions in recidivism. It's a very labor-intensive model, multidisciplinary, 24/7 responsibility, activities out in the community, not within buildings, and that it is likely to be reserved for some of the more impaired individuals within your caseloads. There often are not enough FACT slots within a community for the demand, and so selection of target population is critical to ensure that that particular intervention is used appropriately and has the greatest impact possible. There is a growing literature on the application of illness management and recovery models. Some people are talking about them as wellness management models at this point in time, and that their application to individuals that have criminal justice history is just being tested at this point in time, but it has every reason to believe that they can be associated with improvements in both the substance use component of co-occurring disorder, the illness related to the non-addictive mental illness, and associated with reduced recidivism. We know that for individuals with serious mental illness, that supported employment, getting a person into the community on a job with competitive pay, with coaches as necessary, is associated with a high percentage of those individuals returning to work. There are some modifications to supported employment models that are necessary for justice-involved individuals. If an individual is going to have to report to court or make appointments with probation and parole, that those need to be accommodated within the supported employment model, but there's every reason to believe that those individuals with both serious mental illness and co-occurring disorders can return to the workforce if they're motivated to do so. Roger had mentioned the importance of trauma as a disabling event for many individuals and such a widespread and common experience for individuals with co-occurring disorders in the justice system, and that there are a variety of trauma-specific treatment interventions for individuals that meet criteria for post-traumatic stress disorders that have been associated with positive outcomes and meet criteria as an evidence-based practice and should be in the toolbox for those individuals within your cohort and within your programs that meet criteria related to their trauma experiences. I'm going to skip the cognitive behavioral therapeutic technique for a moment and come back to it. Roger did an excellent job of outlining the components of it, and we're just starting to understand its utility and relevance to those individuals that have serious mental illnesses as well. Having said the importance of EBTs in producing the outcomes that we care and value, both the public safety and public health outcomes, I think it's important to be mindful that not everybody gets access to them. And one of the real critical events in your program development is an analysis of services within your community and what's available and what can be accessed and how it can be financed. I put this slide up, which comes from the National Survey on Drug Use in Households. Actually just got an email about 10 minutes ago that the 2010 survey results are out, and I encourage you to go look at them. It's a SAMHSA data set that comes out every 2 years to see where this particular set of issues lie. But this slide and this pie chart is there to demonstrate that those individuals that answered the phone, that met criteria for both a substance use and a non-addictive mental disorder, co-occurring disorders, and when asked what type of treatment they received in the prior 12 months, what you see here is that the almost 45% of them got a mental health care intervention only, and that 40% of them received no treatment at all, and that only about 11% of the individuals received treatment that might be considered integrated. So I've made the point that the modal individual with a substance use or mental health disorder has a co-occurring disorder, that the treatments associated with good outcome are integrated treatments addressing both problems in a simultaneous and integrated fashion, and yet when the experience, and these are not justice involved individuals, but the experience of individuals with co-occurring in the community suggests that access to this evidence-based practice is less robust than we'd like it to be. I should point out that in the 10 years the survey has been looking at this pie chart, the wedge has grown, and that's a positive event in that there is increasingly more and more providers out there with co-occurring capacity, but it's very important for your programs to identify who they are and to figure out how the justice-involved people you're working with, re-entering into community, can access that evidence-based practice. What we're beginning to understand about individuals with serious mental illness, and majority of which have co-occurring disorders, that it isn't simply their mental illness or their substance use disorders that explains their involvement in criminal justice settings. And so it's a new concept that is coming through research that's been done in the field that suggests pathways into criminal justice setting are complex for individuals with co-occurring disorders. This slide is a small study in Hawaii that was done several years ago, but suggests that there is a direct effect of substance abuse explaining arrest and then involvement in criminal justice settings. There can be a direct effect of having a mental illness. So if I have auditory hallucinations that command me to strike or hit someone, that may produce an arrest and be responsible for my criminal justice event at that point in time. But there are a lot of pathways that aren't related to either substance abuse or mental illness directly for individuals with co-occurring disorder. So what is going on? Well, it turns out through research literature that is growing at this point in time, and this is from Dr. Jennifer Skeen and colleagues, that those individuals justice involved with mental illness actually have more of the risk factors that are associated with rearrest than people without co-occurring disorders, so that we understand from our actuarial analyses that one can make reasonable approximations of risk for rearrest based on static factors like demographics and age of first arrest and nature of crime, but importantly on dynamic factors. And these are criminogenic risk factors that are susceptible to change. And there have been 8 risk factors that have emerged from the literature as most closely associated with recidivism. These dynamic criminogenic risks are listed here on the right. They include antisocial behavior, personality, hanging around with antisocial peers, having antisocial thinking, problems and difficulty within the family, problems at school or work, no meaningful activity during the day, and substance abuse as a dynamic risk factor. And each of these risk factors then have associated responses and interventions that can reduce the risk for those individuals. And so for this audience, a familiar principle in correctional rehabilitation is that of risk need and responsivity, and its application to individuals with co-occurring disorders is being understood as a necessary and important part of our evidence-based practice toolkit. The risk principle is that we want to make sure that we focus resources on those high-risk cases. Those individuals, through their valid testing, have a high likelihood of recidivism, and that we have data out there and a literature that suggests that if we don't concentrate on those cases, include individuals that are lower risk, they actually, through that inclusion as low-risk individuals, have higher rates of recidivism than if no intervention was provided at all. Dr. Ed Latessa, University of Cincinnati, and colleagues has been helpful in illustrating that point. So we want to make sure that we focus our attention on high-risk cases. We want to target the criminogenic needs. So those dynamic factors, those dynamic risk factors, those needs can be addressed through specific interventions. And we want to make sure that when assessment highlights one of those needs in an individual, that there's a matched and paired intervention that can improve on each of those dimensions, reducing substance use, improving antisocial attitudes, substituting criminogenic peers for prosocial peers, that become a part of the treatment intervention and case plan. And the responsivity part to the R&R principle is that the intervention needs to be tailored to the learning style and motivation, culture, demographics, and abilities of the offenders. So we want to make sure not all people learn in the same way, not all people have the same strengths that they bring to the treatment and supervision experience, and we want to ensure that we can address their needs by factoring in these dimensions that explain and predict some of their responsivity. This is really kind of a nice overlap with the needs of individuals with mental illnesses. So, for example, the responsivity issue comes up for an individual that may have significant depressive symptoms related to their major affective disorder, and that we know that it's difficult for those individuals to be motivated, to have energy, to concentrate and focus, and that if those issues aren't addressed, if their depression isn't treated, then they're not likely to take advantage of some of the other treatment and supervision strategies that are being employed. So the treatment of that depression becomes part of improving the responsivity of that particular individual. What we have done, and I will take responsibility for trying to talk about a three-dimensional concept over the phone, but what we have now is an understanding that it's, as we think about reentry and the folks you're working with, it is not sufficient. It's necessary, but not sufficient to simply consider what their substance abuse and mental health needs are. What we also need to take into consideration are their criminogenic risks. And so what this cube represents, and this is just draft and it's in evolution, and we're being guided by representatives of Askin, Ashbit, and Nazadad, is that we want to understand individuals both in terms of their severity of mental illness, their severity of substance abuse, and also the degree to which they have potential for rearrest. And so we're increasingly thinking about ways in which we can use our screening and assessment to identify a target population that will then be responsive to a set of evidence-based practices. I quickly reviewed evidence-based practices that we are aware of with potential to generate good outcomes in individuals with serious mental illness and co-occurring disorders. This is just a graph and a table that Dr. Hank Stedman and I put together, which looked at what the data is for the evidence-based practice as it applies to justice-involved individuals and the potential impact on their recovery and reduction in recidivism. So top on the list, integrated treatment, have some good data for it. The impact is likely to be large. Housing, some minimal data about how it affects criminal justice outcomes, but the impact, is likely to be large. And you can go down the list. The forensic assertive community treatment / forensic intensive case management is another model for working with justice-involved individuals with co-occurring disorders. But what we see is that there are a variety of evidence-based practices with a variety of evidence in the justice population that one should be considering accessing depending on the assessment of the individuals that you're working with. And then lastly, I want to emphasize a point around collaboration, so that we've been talking principally about some services and treatment interventions. Roger did discuss the specialized probation and parole initiatives, but that it really is necessary for there to be integrated treatment and supervision, so that our treatment providers need to be familiar with and work with our community corrections and corrections staff who need to be familiar with behavioral health issues. And this is just a slide that demonstrates the potential through collaboration. It was generated by Steve Ayers at WISP, and that what we see here is that you can get some bang for your buck when you provide, for example, on the third bar, drug treatment, but if you actually integrate that into a supervision strategy, the ability to impact recidivism is considerably greater. So that I know that many of you on the phone participate in collaborative enterprises for those individuals coming out of correctional settings, and it is through that collaboration and application of evidence-based practices that we hope to get our best outcomes. There are challenges to providing EBTs out there, and you all know it. You have to make sure you have the right population with a good assessment matched to the right set of services. It's important that we have a workforce that's competent out there that can deliver the EBPs with fidelity. We have to have adequate facilities and resources for the particular intervention. We have to have the support from our leaders and our policies within our systems to allow for the dissemination of evidence-based practice. This may be facilitated or impeded by local, state, federal regulations, and then always is a challenge to figure out how we get reimbursement for those services that are associated with good outcome. Is there too much emphasis on evidence-based practices? I know it's a word that we hear all the time in all of our settings and all of our conferences. And that while Roger and I haven't provided an exhaustive list of EVPs, we also recognize that there really aren't enough evidence-based practices to cover the range of clinical circumstances and individual complexity that you deal with on a day-to-day basis. So that's a given. However, if you have limited resources and you're trying to select interventions that are going to have an impact on recidivism, it's really appropriate to spend those resources on those practices that have a demonstrated track record at getting the outcome that you care about. So that while we may not have each practice or every practice specifically for the characteristics of the people you're working with, let us use evidence-based thinking, okay, so that we at least can borrow practices that have worked with a similar population. We can combine a practice that has worked in substance abuse with one that's worked with mental health, with one that's worked in correctional rehabilitation. And so this evidence-based thinking becomes the conscientious, explicit, and judicious use of best evidence in making decisions about the care of individuals. So that is the end of our formal comments, and I'm going to turn it over to our moderator, Alexa Eggleston, to facilitate discussion with some of the questions that you sent in.
Great. Thanks so much, Dr. Osher, and thanks to both of the presenters for offering some really interesting information. I do want to apologize for the sound difficulties. We have some storms rolling through our area that I think are causing some problems. So if there's something that you think you missed, this would be a great time to ask a question about it. Want to remind everyone that if you'd like to ask a question, the best way to do that is to use the Q&A panel on the bottom right-hand corner of your screen. That's a better option than the chat function. So again, please use the Q&A function, and again, we will do our best to get through as many of the questions as we can in the next half hour. So let's start with the first question. Do we know when in the reentry process an evidence-based practice can have the most impact?
I can start in taking an opportunity to answer that. I think I mentioned briefly that the first 30 days after reentry is absolutely critical, and then extending, I think, to 90 days. This is where you find most of your the relapses occurring and very high rates of rearrest during this time. And of course, the most common factors leading to reentry failure at these points are discontinuity of medications and also lack of engagement in treatment. And so that really is the window for moving towards engagement in these key services to stave off relapse and recidivism. Also, as Dr. Osher mentioned, stable housing is a significant problem for offenders with co-occurring disorders, and that's a really important issue, obviously, to address at the very onset of the point of reentry to the community. I think another key point that's sometimes overlooked is the period just before release from custody also, or from residential treatment. And this is when the offender's anxiety and stress are pretty high, and last-minute adjustments need to be made regarding treatment appointments, medications, housing, and so forth. And then finally, I would add that the programs that seem to have had good success with offenders who have serious mental illness have found it's particularly important to have staff actually transport individuals from custody or residential settings to their new housing placements in the community and also to initial treatment appointments. Dr. Osher, do you have any other
I would only want to, Roger, I'd only want to emphasize your point that, from the critical time intervention literature, we appreciate that transitions are a particularly vulnerable period for any individual, and particularly those folks leaving incarcerated settings. And so it is really important for us to assure that there is this continuity between institution and community, and that we have a heightened focus on those early weeks and months when a person has just come, is getting back on their feet, associating with a new set of peers to ensure that they have the information and skills they need to make appropriate choices to reduce their own likelihood of returning to incarcerated settings.
Great, thank you. Next question. We got several questions on this topic. People always say that integrated treatment for quadrant 4 persons with co-occurring disorders is preferred, but what is integrated treatment? A number of questions about how you distinguish between integrated programming versus parallel programming.
Okay. It's a great discussion topic. Roger, I'll start if that's all right. And what we know about services integration is that we can talk about integration of treatments, we talk about integration of programs, and then we can also talk about the integration of systems that will support that. I think a definition of service integration that I like is any process by which mental health or substance abuse provider provides services combined either at the level of direct contact with the individual with co-occurring disorders or between providers of programs to ensure that messages are consistent and that both disorders are considered primary. It is critical to appreciate that there is a relationship between co-occurring disorders. It's not simply one of chance, and they occur much more frequently than one would expect just by chance. It is also important to understand that there's always a relationship between the disorders that affect outcomes, and that there is the requirement of effective responses for those individuals if they're going to move forward in their recovery. The services integration, it can be provided by an individual that's cross-trained. It can be provided by an interdisciplinary, multidisciplinary team. It can, at the program level, represent a blending of services between agencies. I think the sub-question of, how do we distinguish between parallel and integrated? Parallel models, which are still used, have the individual attending treatment services for their addiction in one locale with one set of providers, and then for their mental illness with another set of providers, oftentimes in a different setting. It is the case that the messages that one would hear in those settings might not be consistent with one another. And so the burden of integrating these inconsistencies is put on the individual that has the least capacity, that is, that client or returning offender that's got co-occurring conditions. And so the parallel model is one in which we don't have adequate communication at the program level and that the services are not brought together in a meaningful way so that they can address the problems in a simultaneous fashion. And there's no recipe for services integration. I think what it is a commitment on the part of the program and the providers to understand the association between the conditions and emphasize that they are both treated simultaneously and that there's attention to the recovery path for that individual in both their addictive behaviors and those signs and symptoms that are associated with their mental illnesses.
Thank you. Next question. Can you provide more information about housing and supported employment are evidence-based practices? And then just a quick question about references or particular places they could maybe find additional information.
Okay. That probably was on the right side of the column, Roger. So let me start with that. The Corporation for Supportive Housing has a website, csh.org, with a number of research studies that have looked at the impact of supportive housing on a variety of outcomes, including criminal justice outcomes. And so that would be one place to look for literature on it. There was a study that was done by Dennis Callahan and others that looked at individuals that were placed in supportive housing options within New York City compared to a group that did not have that experience, and found that those individuals in supportive housing had these reductions in shelter use, hospitalizations, fewer jail days. They actually had higher rates of outpatient care utilization, which is a good thing, as opposed to inpatient or in-custody care. And that there was an analysis of cost in that study, and it actually looked at the cost savings from avoiding contact with those high-cost service environments offset the cost of housing for those individuals. So we have several studies out there that suggest benefits from supportive housing. Supported employment, the research is less robust, and that I think we need to acknowledge that the evidence-based practice has been successfully applied to individuals with serious mental illness and co-occurring disorders, but its impact on criminal justice outcomes hasn't always been a part of those studies. And so that is in a category of a evidence-based practice for those individuals with co-occurring disorders and a promising practice for those individuals that are justice involved. I think it just requires another set of studies that would sort of validate its application and its attainment of some of the criminal justice outcomes going forward.
Okay. Thank you. Next question. How different is the treatment plan for those who are involved in the criminal justice system and those who are not involved in the criminal justice system?
That's a good question. I don't think there's a huge amount of difference other than in community-based settings, of course, involvement of community supervision, and then, of course, some specialized interventions for individuals who have ingrained criminogenic beliefs and thoughts, values. And I think we talked about the criminal thinking curricula that are part of cognitive behavioral interventions that would be a key part of the treatment plan for offenders. But so I think those are the two major elements, the involvement with supervision and elements that are required for attendance at supervision meetings, as well as your analysis that might occur separately from those at treatment, and then the specialized interventions for criminogenic risks that Dr. Osher talked about.
Yeah, I'd agree, Roger. I guess, and again, individuals, whether they're in criminal justice settings on paper or not, have clinical needs that vary, and it's really an assessment of what those needs are that drives the treatment plan. And that we know that justice-involved individuals with behavioral disorders are more likely to be have homeless histories, more likely to be unemployed, and have some difficulties, increased numbers of the criminogenic risk factors. So all of those issues are likely to come up during the assessment period, and then define the specific treatment plan that's required to assist those folks in both their recovery and in avoiding criminal justice involvement.
Thank you. Are there assessments you would recommend to look at criminogenic needs for criminal justice folks as opposed to the clinical assessments you talked about in the presentation?
This is Roger. I can start with that. And I think there are a variety of different instruments out there. And one of the things we mentioned earlier was there's a proliferation of instruments, and it's hard to keep track of all of those and which ones are good ones to use and which ones aren't so good. There certainly are a variety of risk assessment instruments available. And one thing that we just talked about recently in the discussion was that there's not a single monograph out there that I think adequately captures the differences and nuances between these instruments and which ones should be used in different types of settings. So there, of course, are books and other things out there and different pieces on single instruments, but nothing that does a crosswalk between these instruments. So I'm really looking for NIC and SAMHSA and others to look at some strategies for developing that type of information. But that having been said, there's a variety of instruments out there. The comprehensive risk assessment instruments require both a file review and an interview to examine the set of risk factors that Dr. Osher mentioned that include both static, unchanging types of factors and the dynamic risk factors. Those are changeable over time. And so they're not easy to administer in terms of time frame. They also require training. I would give as 3 examples of the more comprehensive risk assessment instruments: the HCR20, the LSIR, and the START instrument. These 3 are all designed to assist in case management related to treatment and supervision. As I mentioned, they each involve a file review to look at issues such as age at first arrest, number of prior felonies, and so forth, and also an interview with the offender to look at primarily the dynamic factors such as substance abuse, the antisocial criminogenic values and belief systems, and so forth. There are a number of other shorter instruments that have come out. One example is the RANT, which has been developed for drug courts and other criminal justice settings. There's also the LCSF. These don't require an extensive interview, but the flip side of that is that they provide a bit less information about the dynamic risk factors, such as criminal attitudes and beliefs or substance dependence. Back to the 3 more comprehensive risk assessment instruments just for a minute. The HCR20 and the START instruments are both interesting. The START is really for more of a short-term assessment of risk and recidivism. The HCR20 is a longer-term assessment instrument, and they can both be used actually in tandem. And many jurisdictions are actually doing this. Forensic hospital systems, other systems are using these both at the same time. Both these instruments are low cost to administer. They're essentially in the public domain. The HCR20 has a very moderate nominal cost for that. The LSIR that I mentioned has been more widely used in the United States, I think. Historically, it was developed before the other 2 instruments. It's also a bit more costly to administer and more time-consuming. But again, each of those three instruments apply a case management approach that help in treatment planning and triage to different levels of supervision and treatment. I will mention the HCR20 and the START are being used increasingly internationally as the instruments of choice for risk assessment. As I mentioned, each of the instruments require staff training. The instruments have been validated with populations of offenders with serious mental illness. But one caveat that's kind of interesting is that the instruments haven't been validated specifically for co-occurring disorders in most cases. And we think this is probably not a problem because of the high rates of co-occurring disorders within the mentally disordered offender population. So the validation tests that have occurred so far with these instruments have necessarily involved quite a number of people that have co-occurring disorders. The studies haven't broken that out. So we're looking for the research to tell us a little bit more about validation of these instruments down the road. One last thing I will mention about the risk assessment instruments is that several independent analyses of these studies have found that for the comprehensive instruments, such as the HCR, the LSIR, and the START instruments, they're essentially equal in predictive abilities in looking at violence as well as recidivism, so that you can't go wrong with any of those instruments in terms of the ability to predict recidivism or violence.
Thank you. We received a number of questions about therapeutic communities, their effectiveness, and so I'm hoping I can layer on a couple of questions for you. Generally, the effectiveness and what we know about recidivism reduction related to therapeutic communities. For those places that are not able to have a therapeutic community behind the walls in a prison or jail, what are some of the options or other effective things that they could think about doing? And then third, whether there's any research on gang-related issues within a therapeutic community context. And I can repeat those if it's too much to keep in your head at once.
I can start. I think the question was looking at other options. If they're not able to provide a long-term TC in a prison, what other options are there? And I'll start with that. I think that I mentioned before in the presentation that most TCs are relatively long. It's hard to find a TC in prison that's less than 9 months in duration. That having been said, as we know from the accumulated literature and the NIDA principles on effective treatment, that interventions of 90 days or longer are those that are recommended. And for co-occurring disorders, we're finding that interventions need to be a little bit longer, at least a third longer, I think, and Dr. Osher may have some more information on that. So I think for co-occurring populations, whether it's quadrant 3 or quadrant 4, we need to look at a fairly long-term duration of treatment. Although, that having been said, I don't think that we've adequately tested out the reentry models that might examine a use of for example, a 6-month in-custody program coupled with a 6-month out-of-custody program that's of moderate to high intensity. So there's more that we have to learn about that. But there are other options, certainly, than TCs. There's other residential treatment options for offenders. There's also day treatment programs, essentially intensive outpatient models that occur in prisons or jails where individuals hopefully live in an isolated treatment unit within those settings, but then they may receive treatment during part of the day and then go to jobs or educational programming during other parts of the day. I think there's a variety of other options. We don't know the outcome effectiveness of these other types of models other than TCs, because the TCs really are the ones that have been studied most often in prisons. In jails, we have even less information about a variety of options. But I guess long story short is that there's no reason to believe that treatment regimens of moderate duration, such as 6 months, followed by reentry services in the community, can be quite effective for this population. we need obviously more research to examine that and to conduct long-term follow-ups.
The only thing I would add, this is Fred, is that we do have a pretty robust literature on modified therapeutic communities for individuals with co-occurring disorders, both in jail settings and community settings. And Dr. Stansax and colleagues have done a lot of work. The modifications, as Roger was alluding to, are modifications in program length, program intensity, and program content. That is reflective of the responsivity issue as it relates to individuals with co-occurring disorders, to ensure that they're able to actually get the appropriate benefit from a residential setting, treatment, a milieu as treatment experience. And so MTCs are an evidence-based practice for justice-involved individuals with co-occurring disorders. And then I'd like to acknowledge I don't know the answer to the application of PCs or MTCs to gang populations. Roger, I don't know if you're aware of any.
No, I can't contribute to that as well. Not sure of any literature out there on that topic.
So maybe that's a to-do assignment for the Resource Center, Alexa.
Yes. Thank you. Next question. Most research on criminality and recidivism has been conducted with men. Can you speak a bit about the unique needs of female offenders in terms of recovery and recidivism prevention?
I think I mentioned before there are some specialized curricula out there for females. There hasn't been a huge amount of research looking at tailoring those curricula for female offenders. I believe that there is now a trial going on with Seeking Safety would be one example. But I think we know the issues that are salient for the population, and there certainly are unique treatment needs. As Dr. Osher mentioned, this is part of the responsivity principle, is tailoring interventions that address criminogenic needs to the specific areas that in which offenders would be more responsive. And I think with female offenders with co-occurring disorders, we know these have issues related to trauma and PTSD. There's also issues related to parenting. There's fractured families and reunification issues that are really important, that in many cases are first and foremost for the offenders rather than abstinence or other things that we would like them to address. And so I think the good news is that we have a variety of curricula, as I mentioned, that are available to address those issues. I mentioned Seeking Safety would be one, but there's also trauma, recovery, and empowerment. There's curricula on treating concurrent PTSD and cocaine dependence, substance dependence, post-traumatic stress disorder therapy, and a number of others that have an evidence base and that have been used successfully. Again, I think there's more work that needs to be done to tailor these interventions for offenders and also to examine outcomes over the long term.
Thank you. I have just moved to the next screen, which has contact information for Dr. Peters and Dr. Osher as we begin to move towards the tail end of our presentation today. We're going to try and squeeze in a few more questions, but we want to encourage you to reach out to the good doctors as well as the National Reentry Resource Center if your question doesn't get answered today. A similar question in regards to the research for co-occurring disorders among adolescents or juvenile offenders and even that young adult population getting into the 17, 18, 19-year-old. What do we know?
I think we know, as far as screening and assessment, we know that there are some of the same instruments that we mentioned before have been applied successfully with adolescents, and those include the GAIN instrument, the ASI, of which there are several different versions for adolescents. I mentioned the MINI, so that there's some good news there. There's a variety of other instruments specifically that have been developed for adolescents, such as AMAZE-2, the PESQ, the POSIT. So there's a variety of kind of evidence-based practices there for adolescents. There's also a range of specific interventions for adolescents and for juvenile offenders that are on the NREP directory that SAMHSA maintains, and I'd encourage individuals to take a look at that. There's a wide range of information there about different programs that have been shown to be effective for those populations. And they differ, I think, quite a bit from the adult curricula that we were referencing earlier on in today's webinar.
Definitely. I mean, it is critical not to assume that what works in the adult population is transferable and generalizable to adolescent and youth. And so those screening and assessment instruments that will drive treatment planning and then the associated evidence-based practices for needs identified are really unique to those age groups, and Roger's given some resources for identifying those practices.
Thank you. And I think we are at our last question, which is going to be a data question. The question is, our DOC, Department of Correction, is using a variety of evidence-based practices, and we want to track recidivism rates. We are having difficulty tracking this data given that we can't always follow offenders once they leave our walls. What are your recommendations or suggestions?
I have just a couple ideas to start with. If this is a prison setting, is that right?
It sounds like it, yes.
If that's the case, depending on if the prison is returning offenders to a particular jurisdiction, one can go to the sheriff's office in that jurisdiction or oftentimes the prosecutor's office to access data that they maintain for arrests, incarceration, and so forth that can be very useful in tracking individuals. Now, that's a time-consuming task, but these arrangements have been made many times in the past to gather outcome data. And, of course, the other indicator that's used most often by departments of correction is recommitment. And individuals would have to go to their own research departments within the Department of Corrections to select a sample of individuals that have been released from their programs and then track them over a period of time. But that's probably the single most common indicator that consists use of follow-up outcomes for that population.
Yeah, I think the matching of data sets using state IDs is doable. It does require clearance and oftentimes approval, and I say it not minimizing the technical difficulties involved, but those public arrest records are one set of data that one can use with common IDs to match and get some understanding of outcomes as it relates to return to jail and prison settings.
Thank you. And at this point, we are going to conclude the question and answer period. Again, I do want to direct individuals to both the phone number and the website that are now on the screen. I realize we didn't get to all your questions. I apologize, but there are a wealth of resources available at our website, and please also feel free to call that number with your question if it didn't get answered, and we'll be happy to make sure that you have access to the information that you need. With that, just want to again thank Dr. Peters and Dr. Osher for taking time out of their busy schedules to be with us today, and of course want to thank all of you for attending and participating in your great questions, and of course thanks to the Bureau of Justice Assistance within the Department of Justice for sponsoring this event. And again, thank you, Dr. Osher and Dr. Peters. This will conclude our webinar. Have a great day.